Hello, dear colleagues. My name is Mynzhylky Berdikhojayev, and today we have a patient, gentleman, quite young, 35 years old, with seizures and headaches. Okay. Patient has a brain AVM and previously treated several times. Last treatment was at the end of the March. Together with my friend Alberto Gil, we made the embolization for this AVM, and you can see from the ACA territory there is not supply. Okay, oblique view. Yes, as usual, we're doing extracranial. You can see there is a part of the AVM through the meningeal artery. Yes, and from right internal carotid, there is a part of AVM coming from the posterior part. Last time we did a session, we attacked from anterior part together with Alberto, and this time we left mostly the posterior part, and I think it's quite nice, and it's possible to occlude in this session, but it's a quite functional zone. That's why there is a deep part. I think the part is supplying from the ACA territory. Maybe. We need to check. Okay. There is mainly one draining vein. Okay, it's extracranial. And too much tortoise. It's mostly superficial. Okay, let's check again this part. I think it's possible to approach from this part, but I'm not sure we can push the sonic, but we have only two sonics. Okay, let's try to go with sonic till this point, and we can do angiography and fill this part with the additional draining vein. And this part mostly draining posteriorly. Okay, let's check. Maybe we can push headway 17. Okay. There are two parts. Okay. Рауан Маратович, сол жағына кіре берші. Сол жақ наружный сонда. Yeah. Okay, I asked Rowan to go to the left external carotid territory. Okay, maybe we can take something like distal access. But I think headway 17 can do this job. Так, track suspend headway on jet наш пересанс. Екі набор шприц аш пересалысқа. Yes, we prepared 2 patients for today, but we have only 2 sonic 1.535, and it's a problem with tender, and unfortunately we are in this condition. Let's try to do our best in limited resources. Okay. Пока светите пеха. Рон. Не бери солнце. ТМС. И отдельный набор шприцер бар ма? Мынандай болса болады. Уағалейкум ассалам. Яқшымыз. Пока жетеді осы. Просто көре салшы, егер болса болды, болмаса осымен істей береміз. Аша салыңыз. Тағы бір демін су бере салыңыз. As comparing with the previous session, AVM is significantly decreased. There is a recording on YouTube at end of the March. You can go and you can check. Предыдущий эмболизация қашан болды екен, қарай салыңдаршы? 22nd of March it was done. Yes, you can check on YouTube. Okay, we took headway 17 because we're short from we're short from sonic. We have only 2 sonics, and it's unfortunately. Yeah? We are preparing for the private hospital, and maybe in private system the situation will be better, but then it will depend on possibilities of the patient. Here it depends on possibilities of the hospital, and we have too much bureaucracy. Okay. Yes, and in a month I'm leaving my position in Astana. I'm just continuing my job for 1 month before leaving the hospital. And concerning the situation in the country, we decided to start private practice. I hope it's a good decision. I should made it 7 years ago, but now I think it's a time to live. Okay, the external carotid artery is quite big in diameter. I hope we can place our guiding catheter yes, we need to place it here. It's a spasmogenic a little bit. I hope it will be okay. Yes. When you retrieve the guide wire, if it's sucking the air, then there is a spasm. Now it's came without air bubbles, and I hope there is no spasm. Okay, it's a regular headway 17, and we need to push it through that tortuosity. I hope it's possible with the Traxxas 14, and I hope we can manage this situation with this kind of tortuosity. Okay, last time we also attacked this branch through the AC from the left side, and the small remaining part presented. Maybe it's enlarged after that treatment. Stop. Smart mask. Okay, let's try. On Friday, it was a victory day in Kazakhstan and in many of the post-Soviet countries, and there is a vacations because of the victory day. That's why on Friday I can visit the Tashkent, and we did a aneurysm case, and we could do a couple of stenotic cases in Tashkent, and yes, this tortuosity is a quite challenge for the micro catheter and wire. Okay. Smart маскын келес несі қойсыр. Назад. Стоп. Вперед. Осылай. Okay. Yes. If it will go, it will go. Okay, it went. This tortuosity, thanks to Traxxas. Traxxas is smart. I think it's one of the best wires. Okay. Yes, it's very painful when you pass the tortuous segment, but under the general anesthesia there is no problem. Patient under general anesthesia. Intracranial AVM we do mostly in GA. Smart mask. Вперед. Stop. Okay. Thanks to general anesthesia, it's possible. And then there is a spasm in proximal ICA. Okay. The wire is going all the way back, and then we need to go a little bit in frontal direction. push. Okay, let's check from this point. Sometimes it's better to change traxxas for Chikai Black if there is some problem with the... Okay. Okay, let's check. Let's look like this. I think it's a wedge position, and we can push the liquid embolic from this point. I pulled it a little bit more. As it's look like a wedge position. Stop, назад. Ah, there is one more branch назад. Назад. Артериальная фаза гирка. Начальная артериальная. Ага. Еще. Благодаря гитетгену, да? Goes a little bit forward, huh? Stop, smart mask. Назад. Ага. Smart mask. Okay, we will try to push a little bit more. Бери сам. Благодарю. Пережу, головка. Geometriyasını cöndemedi, ne? Geometriyanın cöndemedi, ne? Yes. I hope the geometry will work till the end of this session. It's very important to have a stable geometry function. Yes, now it went to the correct branch. I will try to push a little bit more, if it's possible. Yes, there is a lot of tortuosity, that's why at some point I think it's in a wedge position. Okay. It doesn't move. Doesn't go forward. Yes, it looks like it's a wedge position. Вперед. I think we don't need to touch the venous part. We can stop at the arterial site and okay, let's see. Squid persons. Unik videos. Уника. Наркоз поглубже. Yes, as usual, at this point of the session, we ask anesthesiology team to give a deeper narcosis and dexamethasone. Because of the rotation of the anesthesiology team, we have all the time new stuff. That's why we should ask all the time to do correct steps. It's not a teamwork, but it's okay. We should work at this condition. I think it's not a big problem. Okay, like this we can control the with lateral we will control the reflux, and with AP we will control the venous. Okay, it will go smoothly. There's another branch. It's connected, and at some point it may connect with the extracranial circulation. That's why we need to do it like this. It start moving. We asked Philips engineers. There is a very bad word in Russian language, and also there is some sentences I learned from my French friends. It's a merda, merda. It's a merda. I hope you don't understand it. This system is merda. System is not merda. The Philips machine is okay, but the last tender was given to the local distributing company, and unfortunately the logistic company who has no experience in medical devices attended the tender, and they gave the geometry system and geometry model, and it worked a little bit more than 1 year, and now it's again broken, and now we need to fix it. Yes, it's branches coming from the transocean communication. Okay, maybe it will go like this. Now it's went. Okay, no problem. Okay, так, Брендерсон. Так. We need to do like this and like this. We need to see what part of it will help to check the part going outside. Nice. Yes, when you do the treatment not every day, then there is a problem. The liquid embolic is not prepared, and okay. Tamam. Tarcini bir. Direkt kıyasın. Tarcini etsin. Okay. Yes, it's all the time problem. I think it's extravasation. It's look like extravasation. It's inside the dual layers. Okay, let's wait a little bit. Kas kütürek ana o sırtına çıkıp централ всего. Она же твердый нараз нашивает. There is a branch from back part. А предыдущий харисаш арчаным бардетком. Бардетом это тоже до микрокатетера. До. Еще. Еще до этого. Еще до. Еще. Все, вперед. На ветка барполомка. Что это? Нараз не тут. Okay. It's a prophylaxis of subdural hematomy. Okay. Let's check. Вперед. It's moving all the time. Yes, there is a branch coming from the superficial temporal, but it's not the aim of this embolization. Okay, let's check the right side. It's the left side. The last time after embolization from the anterior part of the AVM, it was a temporary deficit. It was a sensory temporary deficit, and now there is a risk. There is some risk. I think we can go from extracranial again, but this part is very tortuous, and for this branch headway duo is better. With headway 17 I think we do not succeed. And there is a branch coming from the superficial temporal. It's quite distal and tortuous. Going through the bone. There is an MCA branch. I think this branch is the last branch going to the AVM, but this part is very functional. This part is very functional. It's here. I'll just okay. This is a coronary suture, and this part is a motor cortex. It's a leg part, and it looks like there is something small coming here. It's quite big AVM. Huh? This is a deep venous drainage. It's also possible to go through this branch. This branch is going here. There should be some branch coming from the lenticular striator or something from here. Maybe it's lenticular striators coming here. Okay. We have only one microcatheter sonic, and we can go into this branch. And last time we did a selective angio from all other branches, and now remaining part is mostly from here. And there is a PL network. Should we go from this? It's very tortuous, huh? Sonic will not do this job. We can broke Sonic. There is another tortuous part. Okay. This part. It's also possible to go from here to here, if it's needed. Elimination гремза. We have no headway duo. With headway duo, there is no questions, huh? With headway duo, there is no questions. Yes, the option number something, we can put balloon here and push liquid embolic from here, but it's not the aim, eh? Okay, we need to shrink a little bit more. Okay, let's take Sonic, and we can try with Sonic, huh? Sonic пересадше? Один. Продавец от себя Соника. Да, бери солнце. Swaslover. Okay. The next patient with the basal ganglia AVM and patient is ready for the treatment, but mother of the patient is scary from the treatment. That's why we are deciding maybe to observe the patient number 2. But let's see. We will do angiography and then we will decide to treat or not to treat the second patient. Oh, yeah. Ашқыр. Yes, Sheikh Ahmed and Rawan is not married. That's why a lot of power. Шықпады ма? Ой коннектор бере салшы. С хостиком бір ой коннектор бере саласыз ба? Или ана системаның екіншісіне тыға салыңызшы. Новыйға тыға салыңыз. Ладно. Жарайды, ешнәрсе. Ананың давлениесін спускать етіп жібере салыңыз. Алдымен жібере салыңыз давлениесін. Все, жауап қойдым. Кімнің телефоны ма? Сочно. Austin? Oh, okay. Okay. We changed the saline. Saline is 500 milliliter. That's why we should change it quite often. It's a prophylaxis of air embolism. In some places we should work with 200 cc saline. And it's changing quite often. Then we change with 500, but it's better to have 1 liter saline. But now in Kazakhstan it's a standard 500. That's why it's comfortable when you go with the for the different part of the country. You can work at the same working condition, and in Tashkent, in Uzbekistan, the same. We should work with 500 cc. The flushing system is 500 cc. Okay. Now we need to do roadmap. Navigate. Rahmet in Kazakh language is thank you. I said Rawan, thank you. Okay, we need to push the guiding a little bit up. Then it will be a little bit spasm, but it's okay. It's extracranial circulation, and then it's not a problem. Yes, I don't want to take a risk with the extended risk with non-selective catheterization. Oldu öyle. Okay. As the external system is a killer of hybrid and magic and marathon. Okay, we succeeded. Okay, no, it's okay. I scared maybe it's not possible, but it's possible. Huh? Okay. Sometimes it's not possible to go, but today we are lucky, huh? Okay, let's go a little bit up. Yes. The part with the only coil, it's a part we used the Attura liquid embolic, and it's disappearing, contrast is disappearing by the time. Okay, it was like this. You can check it. Okay, it's coming something here. Okay, now it's intracranial, I think. Just a second. It's quite close to the draining vein, huh? Vena vajachna. Okay, I think this is a primary vein, and then we can stop, huh? We don't need to fill all venous system. And now we can pull the guiding. Pull the guiding down. We navigated the system as much as possible. Now we can check both extra and the intracranial. It's merda, huh? Merda. Let's start moving. The geometry is broken, and the engineers from Philips came last week and they did some manipulation, but it's not totally improved. We need to move it maximum here, then we'll move it. There is like this, huh? It's like in church, huh? then sometimes it works. Okay. Maybe at this point it will start to work. Yes, this system is even better than we used to work in Astana. In Astana it's a Canon and it's horrible. I think it's like this. We can start with the Squid 18, 18 мм. Или он не кидался? Okay, 12. Squid 12. Okay. Let's start with Squid 12. This part of the brain is functional, but when there is AVM, the brain starts changing the architectonics, and I hope there is no functional brain in this part. Так, DMSO. Okay. Half of the DMSO, and then we will continue with Squid 12. But in this location, I think it would be reflux because it's not a wedge position. But I'm not trying to fill all this part. We will do as much as possible. As much as possible without touching the venous system. There is quite a lot of AVM. Okay. Okay, it's going to the, I think it's going to the venous system now. Yes, it's refluxing, it's better. Then we are intra-arterially. That part is look like anion passage, super selective. Stop. Yes, first of all it's filling the primary vein and then it goes to the main vein. At this part it's okay. Now we come to the detachable point. That's a good sign. We don't need to occlude early the draining vein. We'll try to do as much as possible, but we don't need to do extra. Yes, it's mostly intracranial circulation. Took a little bit back, maybe it's faced to the internal carotid. Yes, extracranial circulation is not so good visible. Maybe we disconnected. And there is a small MC aneurysm. It's for the future. Good. I think something from the ACA should come from this point. It should connect it with the AVM. Родно. Все. Yes, and for this treatment maybe the feel first technique usually is better, but unfortunately feel is not available in the country. I don't know the reason why feel stopped delivering in the country in Kazakhstan, and we stopped to use fuel nearly 1 year. Fuel жоқ болып кетті. Fuel жоқ болып кетті. Вообще. Шетелде бар, бізде жоқ. Yes, in abroad, last time I have seen it on Ellis, it was used by Professor René Chapeau, and in Kazakhstan, I think last time I used last year. This year it was not available. I don't know why. I don't know the reason it's not available. Таймер қоясыңшы. Так, тағы бере салшы, ана флакон түріндегісін жинап алайық. Тағы біреуін бере салшы. Сейчас он берется. Барвать. Okay, let's continue. Yes, and the weak point of meningeal arteries, at some point they rupture. It's bad and it's good. It's preventing from extra embolization, and the bad point, sometimes you need to push a little bit more, and it's stopping. Yes, maybe sometimes it's not need to inject more. It's a draining vein. We have seen it there, yes. The same partner. Okay, we reached the point of primary vein, and we don't need to do extra. We don't need to do embolization of secondary draining vein. Till this point it's safe. There is a lot of collaterals. Yes, and if we will go from the MCA, and then there is a little bit risk of ischemic. Not little bit, it's quite high risk of ischemic damage. Okay, maybe next time we can go from the deep part. There is a draining vein, this vein, and maybe we can go through the draining vein, and we can finish the deep part, and then we can send patient for microsurgery. Yeah? Or we can recommend the gamma knife, but gamma knife is not taking these patients after embolization. It's quite less AVM, but they're scary. It's quite complex to measure the radiation. Dose management is maybe not so comfortable. Okay, we can discuss. Maybe at the end of procedure I will ask Rowan to do imaging with the gamma knife protocol. Maybe it will be possible. I think we are now including the vein and outside there. On AP it's AVM, on lateral it looks like draining vein. Okay, let's wait. Yes, then it's mixing. So, stop. Then it's good, it's mixing. Қалайсыздар, қалдарыңыз қалай? Жақсысыздар ма? Жақсы, жүріп жатқан. It's quite big, huh? It looks like AVM. Draining vein. It looks like draining vein. Maybe. Call me maybe. Stop. Біз жауып жатқан жер оған сәйкес келмейді ғой, да? Мынау более сырт жағы. Мынау более. Венаның о жақ жағында ғой, мына жерде ғой. It looks like yes, it's this point. This point. Минус қой жүр? Минус. Минус. It's this point, and then yes, it's close to the draining vein. Okay. Yes, it's usually a very complex when you're doing step embolization with the tantalum-based liquid embolics. It's a regular practice. Huh? I don't know what's this. Let's check. It's a vein, huh? Vena, it's not like this vein going up. It looks like it's a secondary vein. This point. Should we stop, Rowan? Should we stop? Patrikpa? It's time to stop, huh? It's look like it seems to me there is a good word if you compress your ass, then it's better. Huh? If you compress your ass, you will be the rich man. It's a Kazakh idiom, huh? Okay. Till now there is no venous congestion, and I prefer to stop at this point. We have last Sonic on the shelf, and I think better to stop and to plan it for the next time, maybe with the resection. Huh? And today we have no so much material, and we have no headway duo, we have no any other. Okay, let's finish at this point. I think we didn't. We tried to do less harm. Let's see after extubation. It's all the time ноли носа. Ноли носа. It's all the time. We need to keep in mind it's better to not to damage the patient. Құдай қаласа бітіреміз, сәл күте тұрыңыздар. Бір 7 минуттай уақыт беріңіздер бізге. We're planning to finish, that's why I asked the anesthesiology team to not increase the general anesthesia. I think it's clear. I will ask Rowan to do expert CT, and then we can decide finish or not. Okay. Good still. Ром. Okay, dear colleagues, CT is ready. It's a protocol when we do intracranial intervention. We all the time do expert CT. As it's it's small amount of liquid embolic in the deep venous system. But the deep venous system is not occluded, and it's a roadmap for one of the next treatments. And we can see the liquid embolic, but it's quite hard to see the other part, and because of the liquid embolics. And the brain is clear. I think there is no mass effect, and I think we can finish this case and see you in next 25-30 minutes. Next case is also AVM, but we will start next case from the angiography. And thank you for watching. See you in 25 minutes. Рома, можно выключать.